Very
growth and growth and development of musculoskeletal system. Yes.
very good. This is the topic. نحن ماشيين على البروجرام اللي عملت لكم اياه.
اي
اوكي؟
واضح.
اوكي سير. اوكي. نحن نبلش.
يلا هلا شكرا.
هلا البلان هي to discuss the normal and compare it to the abnormal بالpediatrics. يا جماعة ما في عيب مثل ما المريض الأهل يجيبون لعندكم كان عنده abnormality وما بتعرفوا شو هو بدكم تبعتون لحدا تاني. لا. You have to know the normal to be able to know what the abnormal is. So this is something which I think is very important. Okay? Now, one of the unique aspects of pediatric care is the dynamic evolution of each individual. From neonate to adolescent, you have to observe the child. See, are there any changes occurring with time? Because believe me, there are many changes that could be very important. During this period, a remarkable process of growth and development takes place in gross and fine motor skills, intellectual, social, verbal skills, body size, gait, and sexual characteristics. Growth refers to an increase in an individual's total body size or to an increase in the physical size of a particular organ or organ system. Development refers to the physical changes of maturation that occur as a child ages. The developmental process encompasses other aspects of differentiation of form, but it primarily involves changes in function that transform humans into increasingly more complex beings. Development is influenced by many interrelated factors, including genetics, physical trauma, nutrition, and socioeconomic status. It is important to know when a child should normally achieve expected milestones. يعني امتى بيقعد، امتى بيقدر يرفع راسه of growth and development so that potentially abnormal situations are evident. So from normal, you will be able to tell what is abnormal. And this is very important. And this should be judged by the physician who is taking a patient's history and performing a physical examination. The significance of various findings must be related to the child's particular age of growth and development. Although no one should expect a 4-month-old infant to be walking. Can a 4-month-old infant walk? No, of course. And you should know that at 18 months, if this infant does not walk, you should know that there's something going on. And that's when you should investigate. Similarly, a 12-month-old child is likely to have some degree of genovarum. لازم تعرفوا انه لما الولد يكون عمره شي سنه يكون عنده جينوفارم وهذا نورمال، مش يعني نيجي نقول لهم للاهل this is abnormal and نيجي نحط له brace. This is not true. This is a normal finding, and with time the child will outgrow it. But if you get a child who is 3 years old, who has genovarum, then this is significant, and this should be treated. This should be warned to the family that this is important. Could it be Blount's disease, or could it be something else? Some form of vitamin D deficiency. So you have to know these things. Normal growth and development. Neonates are primarily reflexive, but they do exhibit some cognitive traits. These traits include showing more curiosity about the face-like figures than about other figures of comparable brightness, as well as a preference for black and white tones rather than gray. Neonates should turn their eyes toward the sound and be able to distinguish their mothers from other people. This is important. Bone and physiologic flexion contractions are typical in a neonate. At birth, the newborn's limbs are maintained in flexion posture. We all know that the child, when he's born, he has a flexion contraction of the hip. And passive movement of the extremities and neck elicits strong flexor tone. بيكون عندهم spasm. ما فيك تجلسلهم وراكم بالnewborns. This is something important. A normal neonate's limbs moves in an alternating fashion when they are stimulated. This is how we get the newborn. Look at the hips, how they are in flexion. Look at the knees of how they are in flexion. This is ideal, but with time, they lose this spasm or this contraction. They become more free and liberal in movement. Normal development progresses from cephalop to caudal, يعني من الراس للإجرين, in a gradual way. It is best in the head, in the cephalop region, but then moves to the neck, the spine, the upper extremities, then to the lower extremities. During the first few months, gaining head control predominates. Hand control, such as ability to grasp objects, follows. As development continues, the infant gains more and more control of the legs. So I repeat, it starts with the head, goes to the upper extremities, to the spine, and then to the legs. To determine whether an infant's growth and development are progressing normally, the examiner needs to find out from the parents what developmental milestones the child has attained and when, and then compare them with the norms. If the child appears to have developmental delays, referral to a physician who specializes in growth and development problems is recommended. Because of the wide variations in the times at which developmental milestones are achieved, and the numerous reasons for delays, the diagnosis of developmental delay can be difficult to make in the very young child. In addition, a child may exhibit delay in acquiring certain skills and unusual rapidity in acquiring others. Yani, you have to realize that this occurs in a visual way. Okay? When a delay is evident, the physician must determine the cause which may be a neuromuscular condition. Could it be cerebral palsy? Could it be muscular dystrophy? You have to investigate. You have to know what to investigate. And factors suggesting a neurologic cause includes failure of normal developmental responses to appear, prolonged retention of primitive infant reflexes. Infant reflexes. You should know what the infant reflexes are. If they are permanent, this is bad. It tells you that this child has a neurologic problem, or a delay in achieving gross motor milestones, such as when to sit, when to make use of his hands to hit objects against one another, or wanting to grab objects, or when to feed himself. All these are important. Many pediatric orthopedic problems result from disorders or conditions that adversely affect normal growth and development. The four major failures of normal growth and development are malformations, deformations, disruption, and dysplasia. Dysplasia we already discussed. You should not forget all the dysplastic conditions, whether dystrophic dwarfism or achondroplasia, or all the ones that we discussed in the lecture on dysplasias. Let's start with malformations. Malformations are structural defects that result from interruption of normal organogenesis during the second month of gestation. During the second month, يعني المرأة حبلت بالتاني شهر. Examples include myelomeningocele, as is shown in the slide below, or proximal focal femoral deficiency, again shown in the slide, the X-ray below. Or they can have polydactyly or syndactyly. So you have to think of all these points. Deformations. Does the child have metatarsus adductus or a normal foot? You should distinguish between the two. Does the child have a calcaneovalgus foot or a normal foot? Deformations, defects in the form, the shape, and the site of body parts caused by mechanical stress, poor position in the uterus, pressure on the extremity in the uterus, the mechanical stress, which may be intrinsic or extrinsic, alters or distorts tissues. Because the fetus grows considerably faster than the infant, fetuses are more vulnerable to deformations. If you're asked the question, if a deformity is going to be apparent, where would it occur faster? In the fetus, within the uterus. Examples include supple metatarsus adductus, calcaneovalgus feet, congenital knee hyperextension, as is shown in the slide, and physiologic bowing of the tibia. Differentiating deformations from malformations is important. During a cursory examination, severe deformations may look like malformations. Careful assessment is essential if the child is to receive appropriate care for the condition. Malformations cannot be corrected directly, whereas deformations can often be reversed relatively easily, either by eliminating شيل الcause of the deforming force or by counteracting the force with stretching, casting, or bracing, as occurs in a mild or stage 1 or 2 club foot. It might require several casts and maintenance, and you get correction. But if you have a deformation, let's say you have a myelomeningocele, this won't correct. You need surgery to correct it. You need things to correct it. But the mild forms of malformations can be corrected, whereas deformations, you cannot. Whereas deformations can be reversed. And its malformations means the patient, I'm sorry, I confused this, and malformations are deformities that occur within the uterus and they can be permanent. Deformations are due to pressure or poor forces being applied to the extremity. So please distinguish it the right way and don't make any mistake and distinguish it just as I did. Disruptions. Disruptions are morphologic abnormalities that result from an extrinsic interference with or breakdown of the normal growth and development process. Disruptions can be caused by drugs or toxic materials. These structural defects may affect organs or systems that were normal during organogenesis. In the slide below, we have a congenital constriction band in the limb and is an example of a Sorry. What about the evolution of proportionate body size? At birth, the neonate's head is disproportionately large, comprising approximately 1/4 of the body's total length. Imagine, 1/4 of the body's total length. And this is the circumference of the head. During the first year of infancy, the head continues to grow rapidly, and the head circumference usually is greater than the circumference of the infant's chest. Keep that in mind. The evolution of body proportions is indicated by a change in the child's upper to lower segment ratio, the relation of the center of gravity to body segments. This ratio is measured as the distance from the top of the head, من راس الهيد للsymphysis pubis, and the lower segment is from the symphysis to the plantar aspect of the foot. This is taken while the patient is standing. This tells you that as the child grows, when early in infancy or in children, you see that the upper portion, which consists from the head to the symphysis pubis, is longer than the lower extremities. At around the age of 10, they are equal. And then beyond 10, the lower extremities become longer than the upper portion. At birth, I repeat, the ratio of the upper segment is longer. At approximately 10 years of age, the upper and lower segments are almost equal in length. After 10 years of age, as the individual becomes adolescents and adults, the ratio normally becomes less than 1. Why? Because the upper extremity becomes longer. As the upper segment becomes shorter and the lower segment becomes longer. Okay? So they start with the upper segment longer, lower segment shorter, 10 equal, and then after 10, the lower extremities become longer. What about physical growth? The head circumference. Large or small head circumference will tell you whether infant or child has microcephaly or macrocephaly. During infancy, it is essential to obtain individual or serial measurements of the patient's head circumference to determine whether the head growth is slower or faster than normal. Head circumference should be measured at every physical examination during the first 2 years and at least biannually thereafter. With the child supine, the examiner places a centimeter tape over the occipital, parietal, and frontal prominences of the head. The tape should be stretched and the reading noted at the point of greatest circumference. Possible conditions that can affect the head circumference and growth include microcephaly, premature closure of the sutures, hydrocephalus, subdural hematoma, and brain tumor. Head circumference should be charted for age and percentile. Height and weight. A child's growth is demonstrated by an increase in the body height and weight within predetermined normal limits is one of the best indicators of health during infancy and childhood. The child's height and weight should be plotted on a standard growth chart to verify that normal progress is being made. So you can see that there are many findings that would let you judge whether the child's growth is normal or not. This shows you the various charts depending on the weight and height growth, what percentile, the length of the child, the circumference of the head. All these have been well described in a textbook by Hensinger. Numerous tables, charts, and graphs depict pediatric growth standards are available in Hensinger's Standards in Pediatric Orthopedics and in Proceedings of the Greenwood Genetic Center. These are all growth references. The World Health Organization published extensive study of child growth, standards for length and height for age, weight for age, weight for length, weight for height, and body mass index for age. Height and weight should be charted for age and percentile. If growth measurements are lower than the 3rd percentile or higher than the 97th percentile, or if a recent deviation from previously stable percentile rankings is noted, further investigation is warranted. Take this as a warning sign to investigate. The word investigate. Now coming to the epiphyseal growth and closure. This is more interesting for us orthopedic surgeons. During normal growth and development, the pattern in the appearance of centers of ossification and fusion of epiphyses in the upper and lower limbs is orderly. This pattern varies among individuals and is different for boys and girls. Over here we have two extremities. One, the upper, and two, the lower. And I tell you, in exams, you should know when the physis closes. You should know when the physis is apparent. You should know in stages of the appearance of physis about the elbow. We ask these questions. We try to ask it as a matter of principle to make sure that you know everything. And believe me, in the elbow, for instance, if you don't know about the physis, if you don't know when the capitellum is apparent, if you don't know when the medial epicondyle closure is, you could miss fractures. You could maltreat fractures. Likewise in the knee, especially around the tibial tuberosity. And you should know that the far majority of growth about the knee is around the knee, more than the proximal aspect, the femur, and more than the ankle. Likewise, in the upper extremity, most of the growth occurs proximally. And distally in the forearm. I have this list. This list. Sorry, I want to drink. If you look at the age and the gross motor skills, I have this in my clinic. If I get children, you know, the far majority of my specialty is pediatric, spine, and tumors. I have this list in my clinic. When I get a pediatric case, at 1 month, they have minimal progress from newborn. They may lift the head briefly, especially if supported in the prone position. At 2 months, they are able to maintain the head and the plane of the body when prone, and partial head control when pulled from supine to the sitting position. So I have this list. I follow it according to the child's age. I try to see, is this child developing normal or abnormal? If I get deviations, I investigate. This is very important. Thus, the orthopedist must understand the ranges of normal when treating the pediatric patient, particularly when interpreting radiographs. As I mentioned, you have to distinguish between a physis and a fracture. When does the physis appear? And see if the fracture interrupted its position. The percentage contribution of each epiphysis to longitudinal growth of the upper and lower extremity long bones is shown in the next coming slide, as I mentioned. And this is the amount of growth that we get. If you see, the proximal femur is 30%, while the distal is 70%. The tibia proximally is 55%. The distal, 45%. The humerus proximally is 80%. The ulna approximately is 80%. The distal is 20% as far as the ulna, while the opposite is for the radius. Tanner's stages of development. This we use in scoliosis. This we use in spinal deformities. Tanner's stages. When did the spine become mature? This is what we use. The physical maturation of a child can also be compared with his or her chronologic age by using the pubertal stages of development as described by Tanner. The Tanner stages of maturation are based on the breast in girls, on the genital size in boys, the pubic hair stages in both girls and boys. The onset of menstruation in a girl is also important. It tells us about the timing approximately when this girl will stop to grow. And this is very important in scoliosis. What should we tell the family? Is the patient mature? How much are the chances that the curves can progress? This shows you in a male. Look at the scrotal. We have divided it into 5 parts. And by doing this, we can tell approximately when the male has become mature. The female, likewise the breast, the size of the breast. And in both, we use the pubic hair. When we have a lot of pubic hair, when we have hair in the armpits, this tells us maturity has occurred. And we know that curves usually progress very slightly when the child is mature. What are the developmental milestones? Gross motor skills, maturation of the central nervous system, which proceeds in a cephalocaudal direction. The approximate ages at which children should normally attain various gross motor skills are mentioned in the next coming slides. By 3 months of age, the infant should be able to hold their heads above the plane of the body when they are supported in a prone position. لما بيكون هي مع بطنه طلعوا عمره 3 أشهر بيرفع راسه. By 6 months of age, the head should not lag when infants are pulled from a supine to a sitting position. And even they hold themselves well in the sitting position. Normally, infants will begin to roll over between 4 and 6 months of age and can sit with minimal external support at 6 to 7 months, as I mentioned. In the slide, you see this infant. He's 5 months old and he's turning from side to side. They should be able to pull up to a standing position by holding onto furniture at 9 to 12 months and stand without support by 14 months. The average milestone of development of locomotion are as follows. The infant should be able to crawl by 7 to 9 months of age. He should cruise and walk with assistance at 12 months, walk forward without support by 12 to 16 months, and run at 18 months of age. Children should be able to ascend stairs with support by 18 months of age and without support by 2 years of age. They should be able to descend stairs with support at approximately 3 years of age and without support by 4 years. On gross inspection, the independent gait of the infant has a wide base. بيمشي شوي يجري بعاد عن بعض. The hips and knees are hyperflexed because they have still a slight amount of spasm in the knees and the hips. The arms are held in flexion and the movements are abrupt. With maturation of the neuromuscular system, the width of the base gradually diminishes. The movements become smoother. Reciprocal swing of the upper limbs begins, and step length and walking velocity increase. The adult pattern of gait develops between 3 and 5 years of age. If we ask you, when does a child become similar in gait to an adult, you should mention between 3 and 5 years. If they are not by this time, you have to investigate. Fine motor skills, the approximate ages at which children normally attain various fine motor skills are listed in the table that I showed you. A child's exploration of the environment by touch and development of manual skills should emerge in an orderly and sequential manner. This is the table I showed you. You should memorize this table. Okay, you should memorize it. It's very important that you do memorize it. Okay? At 3 months of age, the infants can apply lip pressure and coordinate sucking and swallowing during feeding. The sucking reflex is present at birth in all normal, full-term neonates, but usually disappears at 3 to 4 months of age. By 6 months of age, children are able to feed themselves from hand to mouth. By 9 months, children can feed themselves food such as cookies. By 12 months of age, children can pick up a spoon from the table, chew cookies or toast, and drink milk from a cup if assisted. Ya Jama'a, I'm sure some are asking, what does orthopedics have to do with this? You should know these things. They should be in your mind as you're examining a child. Wallah, don't see you. Many times they send you a child who has weakness in the upper extremity. You have to investigate, know what is expected at this age that this child should have, which is normal, and now he is abnormal. Between 12 and 18 months, they are able to feed themselves messily with a spoon and drink from a cup by using 1 or 2 hands. By 24 months, they can feed themselves semi-solid food with a spoon and drink holding the cup in 1 hand or using a straw. Children should be able to purposefully grasp objects such as a bottle or toy rattle by 6 months of age. At 9 months of age, children use their fingers and thumbs to grasp objects and are able to transfer objects from one hand to the other. At 12 months, children's hand skills are such that they are able to hit 2 objects together, voluntarily release objects, manipulate and throw objects on the floor, and hold crayons and imitate scribbling. Between 18 and 24 months of age, their hand skills evolve to the point that they can build blocks, towers, turn pages one at a time, and throw a ball, but inaccurately. Between 2 and 3 years of age, their writing skills evolve from imitating vertical, horizontal, and circular strokes to copying circles. Ambidexterity. What does ambidexterity tell you? When you see that the child has a lack of hand preference, this is normal during the first 18 to 24 months of age. They don't have any preference. But if an infant demonstrates evidence of hand preference during this time, it may be caused by some defect in the hand and arm not being used, and attention should be directed to that limb status. You have to pay attention when the child is below 18 and he chooses a preference of using one extremity and not the other. You should search the other extremity for causes. Why is this child avoiding using that extremity? This may be the first sign of spastic hemiplegia. Personal, social, and verbal skills. The approximate ages at which children should normally acquire various personal, social, and verbal skills are provided in the coming slides. At 2 to 3 months of age, the infants smile when spoken to and vocalize without crying. By 4 months, children turn their head to sound and recognize their mother. And these go on, and you should know them. When does the child begin to laugh? When does he respond to no? When does he begin to call his mama and dada? All these are important, and they should recognize the sound of their parents. By 12 months of age, children should begin to show an interest in picture books and recognize familiar objects. At this stage, they also start cooperating with dressing. إذا عم تلبسهم كنس بتلاقي إنه بيرفع إيديه لحتى يساعدك أو ساعدكم بتلبسوه. Between 12 and 15 months of age, they should be able to speak 4 or 5 words, dada, mama, and they achieve a vocabulary of 10 words, including names. By 18 months, they should be able to speak 3-word sentences by 24 months. We finished from this. You can take a deep breath and say, it's about time we finished. Well, I'll tell you, what I gave you during this first half to 3/4 of an hour are very important. It's very important to the pediatrician and the pediatric orthopedist and to the resident in training. All these are very important. Now we're going to speak about cartilage and bone development. Now we're coming back to straight orthopedics. Formation of the bony skeleton. We have intramembranous ossification, which directly converts the mesenchymal tissue to bone and forms the flat bones of the skull, the clavicle, and most of the cranial bones. Mesenchymal cells come through circulation, they change into osteoblasts, and they begin laying down bone. And this bone is mainly from the periosteum and is known as membranous bone formation. The second type, which is important for length, the membranous is important for width. Endochondral ossification begins with mesenchymal tissue transforming into a cartilage intermediate, which is later replaced by bone and forms the remainder of the exoskeleton and long bones. Intramembranous bone formation is achieved through the formation of calcified osteoid matrix by osteoblasts inside a cartilage framework. It can be found at the periosteal surfaces of bone as well as in parts of the pelvis, the scapula, the clavicles, and the skull. This shows you the bone, the osteoid, with surrounding by osteoblasts, laying down bone, and you have the periosteal layer giving us the bone. You know that you have in the periosteum, you have the cambium layer, which has osteoblasts, which change into active form, and they lay down bone. Endochondral ossification occurs at the growth plates and within fracture callus, and is characterized by osteoblast production of osteoid onto and not within a cartilaginous framework. The cartilage framework ultimately is resolved. Okay, when we say membranous is within the cartilage frame, we know that the bone at the beginning is totally cartilaginous. Now, when you have membranous bone, it's formed by the periosteum within the cartilage framework, while endochondral ossification forms osteoid onto the cartilage formation, and cartilage is resorbed as bone is being formed. Endochondral ossification is one of the two essential processes during fetal development of the mammalian skeleton system by which bone tissue is produced. Unlike membranous ossification, the other process by which bone tissue is produced, cartilage is present during endochondral ossification only. Very briefly, I want to speak about the vertebral limbal development. Of 4 weeks of gestation, the vertebrate limb begins as an outpouching of the lateral body wall. Formation of the limb is controlled along 3 cardinal axes of the limb to form an anlage from proximal to distal, from anterior to posterior, and dorsal to ventral. Interactions between the ectoderm and mesoderm characterize development along each axis and are governed by the interaction of the fibroblast growth factors, bone morphogenic proteins, and several homeobox genes. Formation of endochondral bone and ossification centers. As the development continues, osteoblasts produce in osteoid matrix on the surface of calcified cartilaginous bars and form the primary trabeculae of endochondral bone. The osteoclasts help create the medullary canal by removing the primary trabecular bone. This process of formation and absorption enlarges the primary center of ossification so that it becomes the growth region on each end of a newly developed bone. These growth regions differentiate further and become well-defined growth plates. This shows you of how you have the secondary ossification center, and you have the primary ossification center. Between both, you have the physis. The physis consists of several types of cells: the resting, the proliferating, the hypertrophic cell, and as cartilage is being resorbed and destroyed, and bone is being laid down, it becomes the zone of provisional calcification. You have one nutrient artery, which usually enters the midshaft of a long bone. It divides into two parts. One is given proximally, one is distally, and this supplies the blood or the cells to the zone of provisional calcification. Division within the epiphyseal plate is coupled with the deposition of bone at the metaphyseal side of the bud, and long bone growth begins. At a specific time in the development of each long bone, a secondary center of ossification develops within the chondroepiphysis that I mentioned to you. The secondary center of ossification typically grows in a spherical fashion, such as that of a joint, in a spherical fashion, and accounts for the centripetal growth of the long bone. The rates of division within the centers of ossification ultimately determine the overall contour of each joint. Now, you have to know these. According to the weeks of gestation, 4, 6, 7, and 8, you have different growth of the limb buds, and this table is given for you to know and memorize. I hope you can collect it from Dr. Khalid and memorize it. The normal epiphyseal plate: structure, organization, and function. The function of the epiphyseal plate is related to its structure. In its simplest form, the epiphyseal plate comprises 3 histologically distinct zones surrounded by a fibrous component and bounded by a bony metaphyseal component. The 3 cellular zones of the epiphyseal plate are the reserve zone, the proliferative zone, and the hypertrophic zone. The reserve zone is adjacent to the secondary center of ossification and is characterized by a sparse distribution of cells in a vast matrix. So you have a few cells in a vast matrix, and it is close, or the closest, to the secondary center of ossification. This is a photo micrograph showing the structure and zones of the epiphyseal plate. You have way proximal, you have the reserve zone. Then these begin to proliferate, you have the proliferative zone. Following this, you have the zone of hypertrophy, and then you have a vascular invasion, osteoblasts come, and all the cells, mesenchymal come, the cells come, they begin to lay down bone, and cartilage is resorbed. It is replaced by a woven bone, primitive osteoid tissue. Cellular proliferation in this zone is sporadic, and the chondrocytes in this region do not contribute to longitudinal growth. So the reserve zone only provides cells, but it does not add to the longitudinal growth of the bone. Type 2 collagen content is higher in the reserve zone. Blood is supplied to this zone via the terminal branches of the epiphyseal artery which entered the secondary center of ossification. Next comes the proliferative zone, which is characterized by longitudinal columns of flattened cells. They're not prolonged, they're not hypertrophied. The uppermost cell in each column is the progenitor cell, which is responsible for longitudinal growth. The total longitudinal growth of the epiphyseal plate depends on the number of cell divisions of the progenitor cell. The rate at which the cells divide is influenced by mechanical and hormonal factors. The matrix of the proliferative zone comprises a non-uniform array of collagen fibrils and matrix vesicles. Proliferative zone chondrocytes are also supplied by the terminal branches of the epiphyseal artery. However, these vessels do not penetrate the proliferative zone, but rather terminate at the uppermost cell, and these vessels deliver oxygen and nutrients that facilitate the cellular division and matrix production that occur within this zone. This shows you the vessels of how they go through the secondary epiphyseal center, and then they supply and provide nutrients to the reserve zone over here. This is the provisional calcification zone coming through vessels, mesenchymal cells. They change into osteoblasts and they lay down bone. Okay. The cells in the hypertrophic zone are 5 to 10 times the size of those in the proliferative zone. And because of the growth in columns, this is the weakest area or layer, and fractures in the epiphyseal plate occurs through this layer. The role of chondrocytes in the hypertrophic zone is the synthesis of novel matrix proteins. This is a physeal plate, and you see the reserve zone of how the cells are rare and they are present in a vast zone of nutrients. They have oxygen, but it's rare over here. And then you have the zone of proliferation. These become hypertrophic, and we go into the hypertrophic zone. There's a vast collection of glycogen in the area. Okay, and then this is the metaphyseal bone, the with the mesenchymal cells. Okay, this is the hypertrophic zone. In our opinion, we think it's the most important as far as fractures are concerned and as far as longitudinal growth of bones. You have a defect in this zone, as you recall I mentioned, in achondroblastic dwarf. The hypertrophic zone has the highest content of glycolytic enzymes, and the chondrocytes participate in matrix mineralization through the synthesis of alkaline phosphatase, neutral proteases, and type 10 collagen. The hypertrophic zone is vast. This shows you the zone, the fascial plate. It shows you the resting zone, the proliferative zone, the hypertrophy. They have a high level of glycolytic enzymes. Alkaline phosphatase is high in the hypertrophic zone. These are points to note. The vessels in the reserve zone only reach the periphery. The secondary ossification center has vessels within it. You have to memorize these. You have to know them. What about the metaphysis? The metaphysis begins distal to the hypertrophic zone and removes the mineralized cartilaginous matrix of the hypertrophic zone. The metaphysis is also involved in bone formation and the histologic remodeling of cancellous trabeculae. What do we mean by remodeling? Not only does bone form, you have osteoclasts which resorb bone. They promote funnelization and they tend to decrease the width so as to comply with the diaphysis. The main nutrient artery of the long bone enters at the mid-diaphysis, then bifurcates and sends a branch within the medullary canal to each metaphysis. The capillary loops of these arteries terminate at the bone cartilage interface of the epiphyseal plate. This shows you of how the nutrient vessels come in. You have mainly the nutrient artery which comes through the midshaft of the diaphysis, and one divides into two parts. It gives branches proximally and distally to the plate, to the zone of provisional calcification. It is through these vessels that mesenchymal cells come and converted to osteoblasts, and also you have osteoclasts and promoting the remodeling process on woven bone. You also have metaphyseal vessels coming and supplying the area. At the periphery, at the zones of Ranvier, you have the perichondral arteries, the central artery supplying the periphery. In the center of secondary center of ossification, you have blood vessels, and these blood vessels reach and supply nutrients to the reserve zone. So don't forget this. I'm explaining the basics, and this is a histologic slide explaining exactly what I told. The periphery of the epiphyseal plate is surrounded by the groove of Ranvier and the perichondral ring of Lacroix. I repeat, the groove of Ranvier and the perichondral ring of Lacroix. Three cell types are found in the groove of Ranvier. We have the osteoblast type of cell, we have the chondrocyte, and we have the fibroblast. We know that a certain amount of it, of the node of Ranvier and the perichondral ring of Lacroix, are a fibrous tissue. It holds the secondary ossification center, the physis and the metaphysis together. It gives a certain amount of mechanical force to the area. These cells are active and are involved in division. They contribute to bone formation, latitudinal growth, and anchorage of the perichondrium. The ring of Lacroix is a fibrous collagenous network that is continuous with both the groove of Ranvier and the metaphysis. It functions as mechanical support of the bone cartilage junction. It provides the mechanical force. It sticks them together. Don't forget this. This shows you it. You have the secondary epiphyseal ossification center. You have the node of Ranvier, the groove of Ranvier, the perichondral ring of Lacroix. Over here you have the growth plate. This is مثل ما واحد عم حط adhesion and holding the secondary ossification center to the primary ossification devices. A bit about biomechanics. The reserve zone. The reserve zone has the lowest intracellular and ionized calcium content. I repeat, it has the lowest intracellular and ionized calcium content. Oxygen tension is low in this zone. The proliferative zone, oxygen tension is highest in this zone. In multiple choice questions, we ask, which is the highest zone of oxygen tension? Secondary to a rich blood supply, abundant glycogen stores, and high oxygen tension support aerobic metabolism in the proliferative zone. So in the proliferative zone, you have to know that the cells accumulate glycogen. And in the zone of hypertrophy, you have high levels of glycolytic enzymes because they will destroy the cell and calcium is laid down. So you have to pay attention to this. So you have aerobic, I repeat, you have aerobic oxygenation, aerobic function. These are important. Aerobic metabolism in the proliferative chondrocyte. The hypertrophic zone, oxygen tension in the hypertrophic zone is low. So it's low in the reserve zone, high in the proliferative zone, and low in the zone of hypertrophy. This is secondary to the avascular nature of the region. Because of this low oxygen tension, energy production in the hypertrophic zone occurs via anaerobic glycolysis of the glycogen stored in the proliferative zone. You have glycolytic enzymes, you have anaerobic glycolysis that destroy whatever glycogen is accumulated in the proliferative zone. Hypertrophic zone. In the upper hypertrophic zone, a switch from adenosine triphosphate production to calcium production occurs. And after the glycogen stores have been depleted, calcium is released. And this is the mechanism by which the matrix is calcified. So there's a laying down of osteoid, and calcium is released from the zone of hypertrophy and deposited in the osteoid. So you have the primary woven bone. The region of the hypertrophic zone where mineralization occurs is known as the zone of provisional calcification. This is what we're talking about. This is where we say that osteoblasts are coming through the vessels by changing of mesenchymal cells. We know that osteocytes exist. This is the basis of where funnelization occurs. This is the basis in which the width of the metaphysis fits to the width of the diaphysis. We know that at the junction of the provisional calcification and hypertrophy, slipped capital femoral epiphysis. It involves the hypertrophic zone. Abnormality, as do many other skeletal abnormalities. One of this is achondroplasia. Cartilage matrix turnover. Several enzymes are involved in cartilage matrix turnover, including metalloproteinases, which depend on the presence of calcium and zinc for activity. Collagenase, gelatinase, and stromilysin are produced by the epiphyseal plate. Chondrocytes in an inactive form and then activated by interleukin-1, plasmin, or tissue inhibitor of metalloproteinases. The metaphysis, which is characteristic or characterized by anaerobic metabolism, vascular stasis. Why does infection, I spoke to you, occur in the metaphysis? They have vascular stasis and they have a low oxygen tension, secondary to limited blood supply to the region. What we know, it removes the mineralized cartilage matrix as well as unmineralized. Last transverse septum of the hypertrophic zone. I repeat, the metaphysis, which is characterized by anaerobic metabolism, stress. You have anaerobic metabolism. They have vascular stasis. They have a low oxygen tension. It's secondary to limited blood supply to the region. It removes the mineralized cartilage matrix as well as the unmineralized last transverse septum of the hypertrophic zone. This is very important to know. This is where you have the zone of provisional calcification. The unmineralized portion is removed via the lysosomal enzymes, and the cartilaginous lacunae are invaded by endothelial and perivascular cells. After the removal process is complete, osteoblasts begin the remodeling process, in which the osteoblasts progressively lay down bone on the cartilage template, creating an area of woven bone that I have spoken so much about it, on a central core that is known as primary trabecular bone. Woven bone and primary trabecular, the first bone that is formed. The primary trabecular bone is resolved via osteoclastic activity, as I mentioned, and replaced by lamellar bone, which represents the secondary bone trabeculae. These trabeculae are formed and laid along the line of stress. This remodeling process occurs around the periphery and subperiosteal regions of the metaphysis and results in funnelization, a narrowing of the diameter of the metaphysis to meet the diaphysis. Keep this in mind. Pathophysiology. Overview. Most epiphyseal plate abnormalities can be attributed to a defect within a specific zone or particular malfunction in the system. Most epiphyseal plate abnormalities affect the reserve zone. However, no evidence currently available suggests that any disease state originates from cytopathologic unique of the reserve zone. Any disease state that affects the matrix will have an impact on the proliferative zone. Let us take achondroplasia. Don't forget we discussed this. Achondroplasia originates in the chondrocytes of the proliferative zone. The disorder usually results from a single amino acid substitution, which causes a defect in the fibroblast growth factor receptor 3, FGFR3. This shows you the irregularity of arrangement of chondrocytes in achondroplasia. There's a disorganized fashion. Another condition, which is Jansen's metaphyseal chondrodysplasia, this is a mutation in the parathyroid hormone-related protein receptor affects the negative feedback loop in which parathormone-related protein slows the conversion of proliferating chondrocytes to hypertrophic chondrocytes. In other words, it does not, when you're in the proliferative zone, to the hypertrophic zone. As the proliferative zone occurs, the cartilage cells begin to lay down in columns and they hypertrophy. This, they would have a delay in this process, and this is what we call Jansen's metaphyseal chondrodysplasia. The mutation in the receptor results in continuously active state that is the molecular basis for Jansen's metaphyseal chondrodysplasia. And because this receptor is the shared receptor for parathormone, hypercalcemia and hypophosphatemia can occur. Keep this in mind. This shows you cases of looks of Jansen's disease. And they could, being that they have a problem with hypercalcemia and hypophosphatemia, they end up of having deformities, bowing, widening of the physis, and varus or valgus deformities. All these can occur. Epiphyseal plate mineralization is a unique process because of specialized blood supply to the epiphyseal plate, its unique energy, metabolism, and its handling of intracellular calcium stores. The major factors that affect epiphyseal plate mineralization are intracellular calcium homeostasis and the extracellular matrix vesicles and extracellular macromolecules. Various microenvironmental factors and systemic hormones also modulate this process. Intracellular calcium. The role of intracellular calcium in matrix mineralization is so important that the mitochondria in the chondrocytes are specialized for calcium transport. Compared with non-mineralizing cells, the chondrocyte mitochondria have a great capacity for calcium accumulation and can store calcium in a labile form so that it can be used for release. Histologic studies have demonstrated that mitochondria calcium accumulates in the upper 2/3 of the hypertrophic zone and is depleted in the lower chondrocyte. When the mitochondrial calcium is released in the lower cells, matrix mineralization occurred. This is a histologic image which shows the disorganized arrangement seen in achondroplasia. I have already shown you this slide. What about the effects of hormones and growth factors on the epiphyseal plate? Influence of on the epiphyseal plate mechanics. Hormones, growth factors, and vitamins have been shown to influence the epiphyseal plate through mechanisms such as chondrocyte proliferation and maturation, macromolecule synthesis, intracellular calcium homeostasis, and matrix mineralization. Each epiphyseal plate zone may be targeted by one or more factors that help to mediate the cytologic characteristics unique to that zone. These factors may be exogenous or endogenous to the epiphyseal plate. When we speak about paracrine factors, these are produced by cells within the epiphyseal plate, and they act within the epiphyseal plate, but then on another cell type. When we speak about autocrine factors, they act on the cells that produce them. What about thyroid hormones? The thyroid hormones, T4 and triiodine, T3, act on the proliferative and upper hypertrophic zone chondrocytes through a systemic endocrine effect. T4 is essential for cartilage growth. It increases DNA synthesis in the cells of the proliferative zone and affects cell maturation by increasing glycosaminoglycan synthesis and collagen synthesis and alkaline phosphatase activity. Excess T4 results in protein catabolism, and a deficiency of T4 results in growth retardation, cretinism, and abnormal degradation of mucopolysaccharides. PTH also acts on the proliferative upper hypertrophic zone chondrocytes. PTH has a direct mitogenic effect on the epiphyseal chondrocytes. Furthermore, PTH stimulates proteoglycan synthesis through an increase in intracellular ionized calcium and the stimulation of protein kinase. PTHrP is a cytokine with autocrine or paracrine action. The common PTHrP PTH receptor has a role in conversion of small cell chondrocytes to the hypertrophic phenotype. Calcitonin is a peptide hormone that is produced by the parafollicular cells of the thyroid. It acts primarily in the lower hypertrophic zone to accelerate epiphyseal plate calcification and cell maturation. Adrenal or glucocorticoids are steroid hormones primarily produced by the adrenal cortex. These hormones primarily affect the zones of cellular differentiation and proliferation. The primary influence of glucocorticoids is a decrease in proliferation of androprogenitor cells in the zone of differentiation. Supraphysiologic amounts of these hormones result in growth retardation through a depression of glycolysis and a reduction of energy stores. Sex steroids, androgens, function as anabolic factors. The primary active androgen metabolite is postulated to be dihydrotestosterone, based on the presence of this receptor in both male and female epiphyseal plate tissue. Sex steroid androgens function as anabolic factors. The role of androgens is to regulate mineralization in the lower part of the epiphyseal plate, increase the deposition of glycogen and lipids in cells, and increase the number of proteoglycans in the cartilage matrix. Growth hormone is produced by the pituitary gland and is essential for epiphyseal plate function. The effects of growth hormone are mediated by the somatomedins, a group of peptide factors. When growth hormone binds to epiphyseal chondrocytes, insulin, like growth factor, is released locally. Therefore, growth hormone regulates not only the number of cells containing the IGF receptor, but also the synthesis of IGF-1 in all zones of the epiphyseal plate. Vitamin D, we all are well acquainted with it. It's the active metabolite of vitamin D. This is 1,25-dihydroxy vitamin D3 and 24,25-dihydroxy vitamin D3. These are all hydroxylated, and both of which are produced by the liver and kidneys. A direct mitogenic effect has been reported with 24,25-dihydroxy vitamin D. The metabolite significantly increases DNA synthesis and inhibits proteoglycan synthesis. The level of vitamin D metabolites is highest in the proliferative zone. No metabolites are found in the hypertrophic zone. Vitamin A, carotene, is essential for the metabolism of the epiphyseal cartilage. A deficiency of vitamin A results in impairment of the cell maturation, which ultimately causes abnormal bone shape. Excessive vitamin A leads to bone weakness, secondary to increases in lysosomal body membrane fragility. Vitamin C is a cofactor in the enzymatic synthesis of collagen, and therefore it is necessary for the development of the epiphyseal plate. Biomechanics of the epiphyseal plate. Epiphyseal plate injury. The weakest structure in the ends of long bones is the epiphyseal plate, and the weakest region within the epiphyseal plate itself is the hypertrophic zone. Although the perichondral ring provides some stability, shear forces are frequently high and can lead to fractures at the end of long lever arms, thin, long extremities. The epiphyseal plate injuries occur when mechanical demands exceed the mechanical strengths of the epiphysis to growth plate metaphysis complex. The mechanical properties of the epiphyseal plate are described by the Hütter-Volkmann law, which states that increasing compression across a epiphyseal plate leads to decreased growth. Increase the pressure, you compress the growth. This is a nice slide that I like, and you have to think of all the various forces that can act on the physis in the junction between the reserve and proliferative zone, or so you can expect any tension force on it to affect it. In the zone of hypertrophy, a shear force will affect it. And in the junction between the provisional zone and the zone of hypertrophy, you have a compression force. Look at this slide, and it describes it itself. The epiphyseal plate properties. The morphology of the epiphyseal plate allows it to adapt its form to follow the contours of principal tensile stresses. The contours allow the epiphyseal plate to be subjected to compressive stress. The tensile properties of the epiphyseal plate have been determined by controlled uniaxial tension tests in the bovine femur. The ultimate strain at failure has been shown to be uniform throughout the epiphyseal plate. The anterior and inferior regions of the epiphyseal plate are the stronger. Mechanical forces can influence the shape and length of growing bone, and studies have demonstrated that mechanical forces are present and can influence bone development during the earliest stages of endochondral ossification. The biologic interface between metaphyseal ossification, front, and the adjacent proliferative cartilage is partially determined by mechanical forces, initially in the form of muscle contractions. The function of the epiphyseal plate and its mechanical properties appear to be influenced by both the internal structure and external mechanical factors. Pathologic states affecting the epiphyseal plate. Cartilage matrix defects. All cartilage matrix defects produce some form of dysplasia, which we have discussed, with varied degrees of effect on the articular and epiphyseal plate cartilage. Abnormalities of type 2 collagen cause myasth dysplasia, and some types of Stickler syndrome and spondyloepiphyseal dysplasia. Abnormalities of type 9 collagen causes some forms of multiple epiphyseal dysplasia. And defects in chromosome 10 cause the Schmidt type and metaphyseal chondroplasia. These need memorizing. We like to ask them. Dystrophic dysplasia is a classic example of a defect in proteoglycan metabolism. The disorder is caused by a mutation in the majority in sulfate transporter molecule, which results in undersulfation of the proteoglycan matrix. The phenotype is short stature and characteristic severe equinovarus feet exist. Together they have the hitchhiker's thumb. Together they have a cauliflower ears. Okay, you have to keep this in mind. Mucopolysaccharidosis are 6 disorders that result from defects in the proteoglycan metabolism. These disorders are caused by a defect in the enzymes involved in proteoglycan metabolism with a resultant accumulation of undegraded glycosaminoglycans. The clinical presentation of each mucopolysaccharidosis depends on the specific enzyme defect and the resultant glycoprotein accumulation. Common to all 6 diseases of mucopolysaccharidosis, they have a toxic effect on the central nervous system, the skeleton, the ocular or visceral system. Hypophosphatemia or phosphatasia is an autosomal recessive defect in alkaline phosphatase. This is a characteristic laboratory finding with resultant normal serum levels of calcium and phosphate, but an inability of the matrix to calcify. The hypertrophic zone widens, but no mineralization occurs in the osteoid that is laid down. The zone of provisional calcification never forms. The histologic appearance and effect are similar to nutritional rickets with resultant inhibition of growth. Hypophosphatemic familial rickets is a sex-linked dominant disorder. It is characterized by low serum calcium and phosphorus. Alkaline phosphatase activity is high with resultant abnormal conversion of vitamin D to metabolites. The skeletal changes seen are those typical of nutritional rickets. You have to think of infection. We spoke about the poor circulation and bacterial lodging. In infection, the haversian canals, the osteomyelitis of the cortical bone, issues with associated subperiosteal abscess. In the first year of life, cartilage canals may persist across the fascial plate and serve as an additional conduit for the spread of infection. Severe infection may cause local or total cessation of growth, and in most incidents, inhibited or angular growth results. Irradiation, depending on the dose of irradiation, can result in shortened bones with increased width because of the preferential negative effect on longitudinal chondroblastic proliferation with sparing of the latitudinal bone growth. Nutritional disorders, rickets. Nutritional rickets result from the abnormal processing of calcium, phosphorus, and vitamin D. The common result is failure to mineralize the matrix in the zone of provisional calcification. The hypertrophic zone is expanded greatly with the widening of the epiphyseal plate, flaring of the metaphysis noted on plain radiographs. This shows you a nutritional ricket where you can see that there is widening of the physis, and at the periphery you have some spurs, and this is called the Pilkin spurs. Okay, so these are very important. Scurvy is caused by vitamin C deficiency, results in decreased chondroitin, sulfate, and collagen synthesis. We all know that Collagen is very important for the vessels, therefore they can have hemorrhage. The greatest deficiency in collagen synthesis is seen in the metaphysis, where the demand of type 1 collagen is highest during new bone formation. Characteristic radiographic findings of scurvy, we have a dense zone. Why? Because the ground substance is not formed well. You have excessive calcium and phosphorus depositing on a small amount of ground substance due to the deficiency of collagen type 1. And as a result, you have a dense white line, and this is called Frankel's line. Okay. And of course, we spoke about metaphyseal flaring, osteopenia of the metaphysis. Clinical findings include microfractures, hemorrhage, and collapse of the metaphysis. This shows you patients. I received a patient coming from the Emirates saying that he was mentally disturbed. And they saw this X-ray and they thought of a Ewing sarcoma. They sent the patient to me. I investigated the patient. The patient was a neurotic. He used to get upset and have tandems of increased activity. And I looked at this and I thought of scurvy, and I did various studies on him. And they turned out to have a deficiency in vitamin C. And on giving him vitamin C, this patient was cured. This is in scurvy. You have the Frankel's line. Why? Because you have very little ground substance for calcium to deposit. They also have bleeding in the gums. So the take-home message of this lecture, I don't know whether to call it a boring lecture or an interesting lecture. You have formation of the bony skeleton occurs via either intramembranous bone formation or endochondral bone formation. Intramembranous bone formation occurs through osteoblast activity directly. Endochondral ossification occurs at the growth plate within the fracture callus and within the fracture callus. In the primitive center of ossification, blood-borne precursors of osteoblasts and osteoclasts are delivered by capillaries. This process signals the transition from embryonic to fetal period and first occurs at the humerus. The total height of the epiphyseal plate depends on the number of cell divisions of the progenitor cells. The region of the hypertrophic zone where mineralization occurs is known as the zone of provisional calcification. Slipped capital femoral epiphysis and fractures through the epiphyseal plate typically occur in the hypertrophic zone. The genetic mutation of achondroplasia is a defect in the FGFR3. Epiphyseal plate injuries occur when mechanical demands of bone exceed the strengths of the epiphysis, growing plate, and metaphysis complex. The Hütter-Baldwin law states that increasing compression across the epiphyseal plate leads to decreased growth, Blount disease. Dystrophic dysplasia is a defect in proteoglycan sulfation. Bacterial infection affects the metaphyseal portion of the epiphyseal plate due to sluggish circulation and very poor reaction from the inflammatory reaction, okay, the macrophages. Scurvy, the defense mechanism is poor. Scurvy is caused by a vitamin C deficiency with a resultant decrease in chondroitin sulfate and type 1 collagen. Thank you. So this is the end of the first lecture. I was kind of wondering. Thank you. بدي أسألكم, was I clear in this lecture?
Thank you دكتور جون. Everything is clear وبصراحة interesting lecture وفيها البوينت المهمات. يعني شكرا جزيلا لك، محاضرة أكثر من رائعة، الله يحفظك. هم شباب الدكتور في سؤال معاكم في شيء؟
لازم دكتور خالد يعرفون هالاشياء مهمين كثير، لان هيدي البيسك. Knowing the normal, you will know the abnormal. If you don't know the normal, you cannot judge whether an abnormal condition is abnormal. عارف كيف؟ بدك تعرف النورمال كيف هو حتى تعرف
الابنورمال. يا شور.
طيب خالد بدك نكمل بالثاني سيشن؟
اللي بدك عادي، يعني ممكن نكمل، يعني حد انك ما تتعب زياده. يعني
انا فكري كمل شي نص ساعه 3/4 ساعه لتشيل عن اللكشر مرة الجايه، لان في فوق ال 600 سلايد باللكشر الثاني.
اوكي
خلينا احكي شي هون شي 100 سلايد ومنوقف.
تمام اوكي
يلا رح بنقل.
هيك
But this lecture is very nice. يلي راح أقولكم. شايفينا؟ خالد شايفينا؟ خالد
معك دكتور جون.
Am I clear?
Yeah, very clear. Now is benign tumor. You will proceed.
Look it, I want to tell you. هالlectures عبقول لهم للشباب اخذهم من كل الريفيو كورسز. هالريفيو كورسز بيقولوا لكم شو لازم تدرسوا لحتى تقدموا حيلا بورد، مش بس لبورد العربي، بس you have to study them. وأمني كبير إنه دكتور خالد يعطيكم كوبي. أنا أعطيه كل الحق إنه كوبي على اللكشر ويوزعها ما بيناتكم. اوكي
شكرا. تسلم دكتور جون، الف شكر. ايوه الله يحفظك. هم عم يسمعوك. يعني الان معنا حضور حوالي 80 او 90 واحد من الاطباء موجودين.
Okay. The very first tumor I will be discussing is osteoid osteoma. This is quite common to occur in children. And the male to female ratio is 2:1. It's a small lesion. It's a lesion which measures less than 1.5 centimeters in diameter. وإذا بتطلعوا بالسلايد الإكس-ray of the hip, you see that there is a small lesion surrounded by sclerosis, and within the lesion, you have a nidus, which is calcified. The male to female ratio is 2:1. And the vast majority of patients are between 5 and 30 years of age. The etiology is unclear, but nerve fibers associated with blood vessels within the nidus likely play a role in producing pain. إذا بتشيلوا الcontents وبتعملوا investigation بتلاقوا a high content of prostaglandin and cyclooxygenase. And you see a large amount of prostaglandins. This, we think it could be the cause of pain. What about the clinical presentation? The classic symptom is night pain. You find that the child wakes up at night crying from pain. You give them aspirin, they improve. You give them any non-steroidal anti-inflammatory drug, they improve. The pain is progressive in its severity and can be referred to an adjacent joint. Be careful. Many times I had young people with back pain, and I investigated the patient. The patient turned out to have an osteodystroma and not a disc. So it enters the differential diagnosis of many conditions. The pain is progressive in its severity. And as I said, it is referred to a joint. The most common locations include the femur, the tibia, the vertebral arch, humerus, and believe me, in fingers. I have had a few in the fingers. The proximal femur is the most common site, as I showed you in the previous slide. And this shows it. You see the proximal femur with the osteodystroma in it. And the hip is the most common intra-articular location. It usually occurs in the diaphysis or metaphysis region of long bones. And when an osteodystroma is the cause of painful scoliosis, you find that the scoliosis occurs at the wrong time and place. You identify the lesion on the concave area of the curve, not on the convex area of the curve. They can also result in joint effusions and think that they have a pathologic process within the joint. So you have to look and search and examine well. It is quite common to have some muscle atrophy around it. This is what you should do. Now, it's a benign lesion. It's not an aggressive lesion. So, how does the X-ray appear? يا جماعة, yesterday I was at a conference at our American University of Beirut, and they presented a tumor of the elbow. They presented it with an MRI, with a CT scan, with a scanogram, and that's it. I asked, what about the plain X-ray? يا جماعة, a plain X-ray is very important. In 70 to 75% of cases, you can tell whether the lesion, what it is, by plain X-ray. It is strictly forbidden not to have a plain X-ray. These lesions on plain X-ray are less than 1 centimeter in diameter. Characteristically, they are surrounded by zones of sclerosis, as you see in the neck of this femur. Lesions are occasionally intra-articular, subperiosteal, or medullary, and these cause less surrounding periosteal reaction. Radiographic differential diagnosis includes osteomyelitis, especially subacute osteomyelitis with subsclerotic surrounded, or a ring sequestrum, a Ewing's sarcoma. Why? Because it forms bone. It can occur usually in the diaphysis and metaphysis. Intense and focal increased tracer uptake on technetium-99 bone scans. You can see it in the spine. You see, look at the spine. You see the lesion is on the concave side of the skull. You find that if you detect it early and you remove the lesion, the scoliosis will correct and the whole situation will change and you will be a happy man. MRI may show extensive surrounding edema. The microscopic appearance consists of uniform, thin osteoid seams and immature trabeculae. Trabeculae are lined with uniform plump osteoblasts. 1 to 2 millimeters fibrovascular rim surrounds the sharply demarcated needles. No pleomorphic cells exist, and the lesion does not infiltrate the surrounding bone. It tells you it's a benign lesion. Similar in appearance to osteoblastoma, but the osteoblastoma is larger in diameter, and it has been aggressive at times. Very rarely, but it has. This shows you the osteoid production, and you can see the osteoblasts bounding the osteoid, the trabeculae, and you don't see any mitosis. Now, how would you distinguish an osteoblastoma from an osteoblastoma, which is large? Osteoblastomas occur in the diaphysis of long bone. Osteoblastoma is quite common to occur in 40% in the posterior elements of the spine, and it does occur also in the metaphysis of long bone. Osteoblastoma, metaphysis, osteoma, diaphysis. The size, osteoma at most 5 to 15 millimeters. Osteoblastoma are more than 1.5 centimeters in diameter. Osteostomas are self-limited, but osteoblastoma continue to grow. In osteoblastoma, they have exquisite pain. It's worse at night and relieved by aspirin. In osteoblastoma, they have a dull ache, and they don't respond so much to aspirin. This shows you an osteoblastoma in the diaphysial-metaphysial region of the tibia. You see it, surrounded by sclerosis. This shows you the osteoid seams bounded by osteoblasts. This is a case, I have had several of them, an osteoblastoma occurring in the neck of the talus. The child would come to you suffering from pain. And if you put your hand or your thumb over the area and you press, he will have exquisite pain. So a warning sign, if you have a patient who has ankle pain and he comes to your clinic complaining of pain in that region, bring your thumb into the area of the pain, apply slight pressure. If you see that that child jumps up, then you should take proper x-rays of the area because you could have an osteoma. And on removing it, in the past we used to open to remove it. Nowadays we're using radio frequency. The radio frequency in doing it, we use a probe, and the probe gives you heat up to 90 degrees. It burns the lesion. The disadvantage is you cannot obtain a pathologic specimen in these lesions. Okay, and the problem is if it recurs, then you will ask yourself, did you make the right diagnosis? Okay, now, what about the treatment? The standard of care is percutaneous radiofrequency ablation of the lesion. A CT-guided probe is inserted into the lesion with the temperature raised to 90 degrees for 4 to 6 minutes to produce 1 centimeter zone of necrosis. يا جماعة, when you get these lesions, you have the radiologist who is an interventionist. He knows how to use the CT scan to localize the lesion. He knows how to make use of it to insert the probe in the proper area. Refer this to the patient, to the radiologist. The recurrence rates after radiofrequency ablation is less than 10%. Contraindications include lesions close to the spinal cord or nerve roots. Now, I would like to mention here, nowadays we're doing it more and more because we found that the CSF is a cooling agent. And if the lesion is not very close, you can do it. There are others who have been using intrathecally cooling agents. And by doing it, they were able to do an RFA of an osteoma of the spine. The surgical treatments have included surgical resection or bury, where you go under CT scan, you insert your bore within the lesion, and then you bury it out. Although the lesion must be localized preoperatively to identify its exact location. In lesions around the hip, patients often require internal fixation, sometimes with bone grafting. And if a large portion of the cortex is removed with the lesion. So you have to keep this in mind. Long-term medical management with aspirin or non-steroidal anti-inflammatory drugs can relieve symptoms after an average of 3 years because these lesions have a limited growth. Depending on the age of the child and the duration of symptoms, removal of an osteoma associated with a painful scoliosis will allow resolution of the curve without further treatment. يعني لما بنشيلهم, and if you're early, if it's less than 1 year, if you, most of these lesions are difficult to diagnose. We have time to diagnose them. It's important to mention that in the past, we used to diagnose them quite often by injecting a radioactive substance, technetium, and then localizing it in the spine. It was quite accurate. Why? Because these lesions have immature collagen and they have a good blood supply. And these 2 points will increase the uptake of the radioactive technetium to the area. So this is a point you have to keep in mind. Osteoblastoma. Osteoblastoma is a rare, progressive, benign osteoblastic tumor. The male to female ratio is 2 to 1. Osteoblastomas are much less common than osteoid osteomas. The vast majority of affected patients are between 10 and 30 years of age, and the etiology is unknown. This is an osteoblastoma of the pedicle through this axial cut. It occurs in 40% of the cases within the spine. It's a progressive lesion. Why? Because we have had the lesion starting in the pedicle. On follow-up, we noted that it goes down to the vertebral body. In around 1 to 2%, there have been cases of metastasis. Osteoblastoma show an interlacing trabeculae surrounded by fibrovascular connective tissue, and you have osteoblastic rimming around the trabeculae is seen. This shows you the site of which osteoblastomas are common to occur, but the highest incidence is within the spine. This is an osteoblastoma occurring in the humerus. The differential diagnosis is a chondroblastoma, in osteoblastoma, a subacute infection. Keep this in mind. This is an osteoblastoma. When it involves the spine, it is most commonly in the posterior arches. It does occur in the pedicle, and it can spread to the vertebral body with time. This is an osteoblastoma. The cells appear innocent. There's rimming of the osteoblast around the trabeculae. It's a slowly progressive, dull, aching pain of long duration that is less severe than that from an osteoid osteoma. So if you compare the pain, it's less than that of osteoid osteoma. Night pain is not typical, and aspirin does not classically relieve the symptoms. Neurologic symptoms can occur because the spine is the most common location for osteoblast. So you have to think this. I mentioned this in the previous slide. This is another slide telling you, and to know the difference, you have to memorize this slide when Dr. Khalid gives you the lecture. Other locations include the diaphysis of the metaphysis of long bone, while the osteoid osteoma is more common in the diaphysis. It does occur in the mandible. Related swelling, muscle atrophy, and limp may occur because the lesions are large and present for a prolonged period of time. Osteoblastomas may be associated with osteogenic osteomalacia, oncogenic osteomalacia. Imaging appearance, it's a radiolucent lesion. It's from 2 to 10 centimeters in size, so it's larger than an osteoma, with occasional intralesional densities, cortically based 2/3 more often than the medullary 1/3. It's an expansile and extension into the surrounding soft tissues and rim of reactive bone around the lesion. 25% of the lesions have an extremely aggressive appearance and are mistaken for malignancy. Radiographic differential diagnosis includes osteosarcoma, aneurysmal bone cyst, osteomyelitis, and osteoid osteoma. Three-dimensional imaging CT MRI is necessary to fully evaluate the extent of the lesion prior to surgical treatment. Histology is similar to osteoid osteoma, but with increased giant cells. Irregular seams of osteoid separated by loose fibrovascular stroma. Osteoid is rimmed by prominent osteoblasts that are occasionally large and epithelioid. Most commonly, there is a sharp demarcation from the surrounding bone. 10 to 40% are associated with secondary aneurysmal bone cysts. Don't forget this. Numerous mitotic figures may be presented, but are not atypical. It is important to differentiate osteoblastoma from osteosarcoma, although giant cell tumor and aneurysmal bone cysts are also similar in appearance. Treatment: osteoblastoma is not self-limited like osteoblastoma and requires surgical treatment. In most cases, curettage and bone grafting is adequate to achieve local control. Nerve roots should be maintained when treating spinal lesions. Occasionally, en bloc resection is required for lesions in the spine. Parosteal osteoma. It's a rare, self-limited deposition of reactive bone on the surface of the cortex. You can see it on the skull. You can see it in other regions. It's a collection of bone on the surface of the cortex. Adults are most common in their 30s to 40s, and the etiology is not known. The cause, but often a history of trauma is reported. Clinical presentation includes a long history of gradual swelling or dull pain. Occasionally, incidental radiographic findings are present. Classically, osteomas are found in the craniofacial bones, but rare presentations in other parts of the skeleton include the long bones, the tibia, femur, pelvis, and vertebrae. Multiple osteomas are associated with Gardner's syndrome. It is an autosomal dominant situation, which also includes colonic polyps, fibromatosis, cutaneous lesions, and subcutaneous lesions. These osteomas are shown in this patient. You can see it over the forehead. You can see it even around the mandible. Imaging appearance. Look at, first of all, before I go into it, you say, what is this fellow showing? This is an osteochondroma. This is not an osteochondroma, my friend. If you look at the medullary cavity, it's not in continuity with the parent marrow cavity. That's one. Number two, if you look at the lesion, it's pointing towards the joint and not away from the joint. And you see that the block is solid bone. It's a uniform, dense lesion attached to the bone cortex with a broad base ranging from 1 to 8 centimeters in diameter. It is well defined with smooth, lobulated borders, no cortical or medullary invasion. It's best noted on CT scan. Radiographic differential diagnosis includes parochial osteosarcoma, heel stress, fracture, and osteoid osteoma. What about the pathology? The histology appearance is of mature hypocellular lamellar bone with intact eversion system. There is no atypical cells present. Treatment, non-surgical treatment is preferred for incidental, minimally symptomatic lesions. Biopsy should be performed if the diagnosis is unclear. Local recurrence of the lesion suggests it was initially not recognized as a parochial osteosarcoma. This is more and more. You see, the medullary cavity of the stalk is not in continuity. It's bone, it's parochial bone. Okay? This is a bone island or inostosis involving the vertebral body and the calcaneum. Bone islands or inostosis, they are usually small, but occasionally large deposits of dense, compact bone within the medullary cavity. Demographics, bone islands occur frequently in adults, but their true incidence is unknown because they are usually found incidentally. The etiology, possible arrested resorption of mature bone during endochondral ossification. So the source is arising from the physis, and it is mature bone which becomes separated and gives you the dense appearance. Clinical presentation. This non-tumorous lesion is asymptomatic and found incidentally. Any bone can be involved, but the pelvis and femur are the most common. Osteopoikilosis. Pay attention. This is a condition you hear spoken in lectures. Osteopoikilosis is a hereditary syndrome that manifests as hundreds of bone islands throughout the skeleton and usually centered about joints. Radiographic appearance is a well-defined round focus of dense bone within the medullary cavity, usually measuring from 2 to 20 millimeters in diameter, occasionally radiating spicules of bone around the lesion that blend with the surrounding medullary cavity are present. Approximately 1/3 of lesions show increased activity on a bone scan. This is a bone island. It's well demarcated. It's well localized. It's a benign lesion. The cortex is not eroded. This tells you it is a benign lesion, and we believe that it's due to a certain amount of bone escaping from the growth center, the physioplate, and becoming localized. No surrounding bony reaction or edema on T2 weighted MRI. Low intensity on T1 and T2 weighted MRI. Radiographic differential diagnosis includes a well-differentiated osteosarcoma, osteoblastic metastasis, and bone infarct. It's nice to keep this in mind. It's nice to have a differential diagnosis. Put in your mind osteosarcoma, osteoblastic metastasis, and bone infarct. Don't forget this, please. What about the pathology? Bone islands appear histologically as cortical bone with a well-defined lamellar structure and eversion system. The border between the lesion and the surrounding medullary bone shows no endochondral ossification. The treatment. No treatment is required, but follow-up radiographs should be taken if there is any question and doubt about the diagnosis. We don't worry about the bone infarct, but we worry about an osteosarcoma, okay? We worry about a localized zone of metastasis, osteoblastic metastasis. You have to follow up these patients. Solitary enchondroma. Enchondromas are benign tumors and comprised of mature hyaline cartilage and located in the medullary cavity. Demographics. Enchondromas can occur at all ages. It's most common in patients between the ages of 20 to 50 years. The incidence is unclear because most lesions are found incidentally. The etiology, enchondromas are thought to be related to incomplete endochondral ossification, where fragments of epiphyseal cartilage displace into the metaphysis during skeletal growth. These are the sites in which enchondromas occur. They do occur quite often in the pelvis, but we worry when they occur. First of all, they have to grow to large sizes for us to discover them, or they are discovered incidentally. And these, the more proximal an enchondroma is, the more likely the chances are for metastatic or for tumor changes or tumor metaplasia or changing to a chondrosarcoma. They occur in the fingers. You have what is characteristic? طلعوا على هالليجن. You see, it's not very aggressive. It has not penetrated the cortex. But in the matrix, you have zones of calcification. Cartilage is undergoing calcification. You have multiple calcifications. But I'll tell you something. Usually the calcification is a typical popcorn appearance. It's not haphazard. And you can have it in all the fingers. Look at the thumb, the distal phalanx, it's involved. You see that there is cartilage, and in each lacunae is one cell. Rarely you have two cells, and it is benign. You don't see mitosis. This is another. It's mainly in the metaphysis. Most enchondromas are asymptomatic and are noted incidentally when radiographs are taken for other reasons. Lesions in the small bones of the hands and feet can be painful. They can be painful, especially after pathologic fractures. When a patient presents with an enchondroma and pain in the adjacent joint, the pain often has a cause that is unrelated to the tumor. If the patient has pain and the radiographic appearance is suspicious, low-grade chondrosarcoma must be considered. Ladies and gentlemen, when you have an enchondroma in bone, and you see that it is within the medullary cavity, impinging on the cortex, and if this scalloping, you should be suspicious. If there is pain, you should be suspicious. If you do a technetium scan and there's increased uptake, you should be suspicious that you have a low-grade chondrosarcoma. Half of all enchondromas occur in the small tubular bones, with the vast majority in the hands. Enchondromas are the most common bone tumor in the hand. Other common locations include the metaphysis or the aphysis of long bones, proximal humerus, distal femur, tibia. Enchondromas are rare in the spine and pelvis. You see in these slides, you see localized chondromas. They're not eroding the cortex, neither in the proximal humerus and neither in the distal femur. You see that they form masses in the hand and can lead to fractures and deformities. Enchondromas are classified by King as inactive or latent bone lesions. The incidence of malignant transformation is less than 1%. We used to think of it more. Now it has decreased to 1%. There is another type. We have multiple enchondromas, more concentrated on one side, and this is known as Ollier's disease. The incidence of transformation is higher. And if you have associated with it hemangiomas, known to be later called Maffucci syndrome, and these are very highly associated with transformation to chondrosarcomas. A dedifferentiated chondrosarcoma rarely develops from a solitary enchondroma. Enchondromas begin as well-defined lucent central medullary lesions that calcify. Over time, they appear more diaphyseal as long bone grows. The classic radiographic appearance involves rings and stippled calcifications within the lesion. Lesions can be 1 to 2 centimeters, 10 centimeters in size, and you can have small endosteal erosions. This is a enchondroma. You see that it has one nucleus in all. Cortical thickening and destruction suggest chondrosarcoma. The radiographic differential diagnosis includes a bone infarct and a low-grade chondrosarcoma. The radiographic appearance is more important than the pathologic appearance in differentiating an enchondroma from a low-grade chondrosarcoma. Enchondromas frequently have increased uptake on bone scans due to continued remodeling of endochondral bone within the lesion. MRI is not necessarily to be done for diagnosis, but shows the lesion as lobular and bright on T2 weighted images with no bone marrow edema or periosteal reaction. The gross appearance is of blue-gray lobulated hyaline cartilage with a variable amount of calcification throughout the tumor. The low-power histologic appearance is of mature hyaline cartilage lobules separated by normal marrow, which is key to differentiating an enchondroma from a chondrosarcoma. Endochondral ossification encases the cartilage lobules with lamellar bone. Lesions in the small tubular bones and proximal fibula are more hypercellular than lesions in other locations. Enchondromas and long bones have abundant extracellular matrix, but no myxoid component. The cells are bland with uniform, dark, stained nuclei. They have no pleomorphic necrosis, mitosis, or multinucleate cells. This again shows them. The treatment is symptomatic lesions require no treatment. I repeat, require no treatment, but should be followed with serial radiographs to ensure inactivity. Rarely, when pain due to other causes is excluded, symptomatic enchondromas can be treated with curettage and bone grafting. Pathologic fractures through the enchondromas in small tubular bones should be allowed to heal prior to curettage and bone grafting. If radiographs are suspicious for chondrosarcoma, then surgery is necessary. A needle biopsy is not reliable to differentiate enchondroma from low-grade chondrosarcoma and should be used only if confirmation of the tissue type is needed. I think I will stop here because I didn't take any break. And next time we will start with Olli's disease and مفوش. شو رأيكم يا جماعة؟
شكرا دكتور جون. الجماعة بيسلموا عليك ونكمل على قولتك الأسبوع الجاي قصدي نكست فرايداي.
بدك أسبوع
يعني
جاي أو أسبوع يلي بعده مثل ما بدك.
اللي بعده
يلي
يعني
بعده.
أسبوع أكثر. أيوه.
شو أسبوع جاي أو لا؟
اللي بعده يا دكتور جون.
لا اللي بعده. I think it's good لأن لحتى أميز هؤلاء الشباب. وشغلة تانية صدقني خالد لازم تعمل لهم فحص كل مدة. And this will keep the knowledge in their head. They will not forget it by studying. And they will have everything before any exam abroad. And it will make their life easier. Okay? Yalla. Yalla. Okay. Yalla, bye.
باي باي.
Bye.
باي.